Yesterday I
He
recorded.
you recorded my thing.
Yeah, I will. Send it in
Okay.
YouTube, and you can. Yeah.
Okay.
Thank you. Thank you, doctor.
Okay, so yeah, history was and relative systemic illness regarding these are the hearing loss, other visual problem, and no other thing. Oh yeah, SLE. These are all include relative systemic inquiry. So next is
Yeah, now we are
yeah,
going to, yeah.
yeah, Pakistani Air Force bind.
And then we have to go for, let's make another page with head SS that you
Oh
were
yeah,
talking
head
about.
SS.
We just
Yeah.
read.
Head SS. Okay, so head SS if age is less than 10 years, then only SS. Less than 10 years, that means not adolescence. In that case, only SS. Only SS. If it is more than 10 uh, years, then it is headache. Then it is head SS. So this is
Doctor, can you explain what is that less than 10 and greater than 10?
less than 10 years of age, your patient. If your patient age is less than 10 years, in that case, you have to take only two history. That is SS. That is school history and social history, socio-economic history. SS means
Socioeconomic and which history? Socioeconomic, another one?
so it school history.
School history, okay. And social economic. Oh. Oh.
So socio-economic history. And if it is more than 10 years, in that case, you have to head S. Head for home
Home,
home condition,
for education. Yeah,
home
home
condition,
condition.
Doesn't
condition.
come out.
Then E for education,
Education?
education, and another one, education and
Go for
eating,
that.
eating, education and eating. Mm. Then A for activity. A for activity. That means really physical activity. Then EAD, na? D for drug use or substance abuse, drugs, cigarette,
Yeah.
alcohol, or any substance abuse use. Then D for develop. What?
S for school,
Sui-
socioeconomic, and sexual.
S for
See.
suicidal.
Suicide?
One is suicidal. D for depression. One is depression. Another D is for depression. S for suicidal. Then sexual.
2S, not
And
3S.
actually 3S.
Yes.
Yes. Here is yes. Suicidal, then safety and sexuality. Oh, another one is socioeconomic. Here also socioeconomic history required.
Yeah.
So D for say depression, then S for first says suicidal tendency, then S for sexual history, then S for socioeconomic. Socio, no. So this. So ultimate this history only relevant cases you have to take relevant history. Not all cases you have to take head S or SS. Okay, so
Okay, let's go for next investigation. First is urine,
yeah, first
bedside
is
urine,
urine examination. So here we do deep
urine
slit.
dips,
Yeah, first is
and
deep
then
slit.
PC
Then
ratio, uh, PC ratio, and then
then
is
Boys and Hassan, be
uh,
careful.
urine PCR, protein creatine ratio. Then
yeah,
urine routine.
routine examination
Uh,
for what? Casts?
cast RBC and protein routine
Okay.
and microscope examination. That is urine. Then
Okay.
okay, then urine after urine, yeah, biochemical, na biochemical. So here is urea, full blood urea creatinine,
Yeah, it is like RFTs and peripheral film for
RFT,
HUA
PBF, acha, yeah, PBF for ACUS, urea
and
creatinine.
I think this is
No, no.
Okay, so biochemistry urea,
uh,
calcium phosphate, other thing, elective, all urea, creatinine, calcium phosphate, electives, blood test. Okay, yeah, these are not so much.
why LFT?
Yeah, only
Yes, calcium.
calcium, urea, creatinine is enough. This. Okay, so then is hematological, then hematological PVF here, na? So here is calcium phosphate, calcium phosphate. So next thing is hemato. Hemato, here is full blood count, uh, full blood count, then PVF, then other full blood count and coagulation screening. Okay, coagulation profile, coagulation profile. Okay, then hemato, yeah, immunological, na, ASO titer,
Yes, ASO titer and throat swab cultures, I
yeah.
guess.
Yes.
Okay, so ASOT or beta NTDNSB,
Yes, it is ANA, anti-DS, DNA,
DNS,
anti-GPM.
DNSB, AS, it is AS, this type, anti-DNSB. Here is anti-DNSB and throat swab for AS, yeah, throat swab. So throat swab, this. And next one is so urine, bio, hemato, immuno, imaging. Imaging is ultrasound. Imaging is imaging, imaging, imaging is ultrasound, ultrasonography. Another one, microbiology. Oh, it is microbiology. Sorry. So microbiology is that is microbiology. Microbiology. Then immunology. Sorry. Microbiology. Then immunology. Immuno is C3, C4, C3, C4. Then Na. First line is C3, C4, ANA. It's C3, C4, ANA. And IgA, na? IgA level for what? IgA nephropathy. IgA. And second line is anti-DNS, anti-DNS DNA, and Anka Pianka, other thing.
Yes,
Okay.
it's anti-GBM, etc. Yes, glomerular best.
Anka, DNA, Anka, and anti-DS DNA, and anti-GBM, and renal ultrasound. So our differentials already we mentioned that differential first is UTI, then UTI, then AGN. Then according to the other relative relevant symptom, we can DD for HAS or G6PD or HSP or lupus nephritis or hemolytic disease, and anything. Okay, we read.
Yes, let's read it.
Hmm.
Sequelae of the
Bacterial infection, renal aquatic exacerbation, IgA nephritis, HSP, and IgA nephropathy, then Barger disease, IgA nephritis, IgA nephropathy. I do think here. Yeah, these are the AGN, messenger proliferative, then Alport syndrome, and Anka, that is good pastor. Nowadays it is another name. Globular basement membrane disease. What is Anka positive? It is Anka positive. This is good pastor disease. Globular basement membrane disease. New name. Here is lupus nephritis. SLE or lupus nephritis. Okay, so here is HAS is absent here, and hemolytic disorder G6PD. Okay, so treatment. So
yes, you have to treat it. You have to copy paste this treatment.
yeah,
Admit.
admit first. Okay, so treatment is just read. We read
Yes,
admit,
it is.
recurrent, then
Admit and review current medication and reduce doses. Stop all nephrotoxic medications. Strict fluid balance monitoring and management. See acute kidney injury guidelines. Treatment of volume overload hypertension. Uh, furosemide. See hypertension guidelines. Severe cases of fluid overload will require dialysis. Treatment of abnormal chemistry consequent to renal failure. See acute kidney injury guidelines. Oral antibiotics, phenoxymethylpenicillin, if tolerated, able to take tablets, amoxicillin, suspension for 10 days. If penicillin allergy, azithromycin for 5 days for post-streptococcal glomerulonephritis. So this is important. Nutrition encourage low salt, low potassium, high carbohydrate diet.
low.
So what important is we have to admit the child, we have to decrease the nephrotoxic drugs, we have to see acute kidney injury, treat and manage acute kidney injury, and we have to treat and manage hypertension. Then we have to give antibiotics that should be over oral most probably.
Yeah.
Amoxicillin suspension or phenoxymethylpenicillin. And if allergic, azithromycin for 5 days. And nutrition encourage low salt and low potassium diet. So discharge from hospital is BP under control, passing urine normally on free fluids, and renal function improving.
Okay, so estimate for only hypertension.
Yeah, it's even for volume overload as well.
Yeah, volume overload. Okay, so hypertensive crisis, severe hypertension, overload, treatment abnormal renal, acute kidney injury, phenoxymethyl penicillin if tolerated or able to take amoxicillin suspension 10 days. So 10 days is important. And if allergy, then erythromycin 5 days for post-streptococcal glomerulonephritis to eradicate gas group A streptococcus. Okay. Then discharge such a if BP control, then passing urine normally, renal function improve, and potassium is normal. So subsequent management, these are important. Subsequent management, follow up, these things are different or specific. So follow up or progression of the PSGN, gross hematuria, oliguria, abnormal chemistry, usually resolved by 2 to 3 weeks. Okay, so gross hematuria, abnormal chemistry, or oliguria usually resolved by 2 to 3 weeks. BP usually normal by 3 to 4 weeks. Serum C3 usually normal 8 to 10 weeks. Proteinuria usually resolve 6 months. So microscopic hematuria usually 12 months. So this is a sequentially. So 2 to 3 weeks first, then 3 to 4 weeks, in then 8 to 10 weeks, then 6 months, then six 6 months, then 12 months. So just remember, first is gross hematuria, oliguria, and other biochemistry 2 to 3 weeks. Then BP 3 to 4 weeks. Then C3 level, C3 is number 3, so it is 8 to 10 weeks. C3 is 8 to 10 weeks. Then proteinuria, usually 6 months, and microscopic hematuria 12 months. So you can repeat this.
Okay, first of all is gross hematuria, oliguria, and abnormal chemistry, 2 to 3 weeks. Then BP 3 to 4 weeks. C3 normal by 8 to 10 weeks. And proteinuria 6 months, and microscopic hematuria usually resolved by 12 months. So, do you remember we had this one of this question, microscopic hematuria? So, where do we need to refer? We don't need to refer anywhere. It's just come in the clinic again for ATM because it resolves by 12 months.
By 12 months, yeah. Microscopic by 12 months, and proteinuria 6 months, then C3 8 to 10 weeks, then BP 3 to 4 weeks, and gross hematuria is only 2 to 3 weeks. Okay. Indication of the tarsal, when to refer, this is also important. When to refer. So first is significant proteinuria, that is PCR is more than 200 milligram per millimole. 200 milligram per millimole. That is ratio, urinary protein creatinine ratio. Then family history of the glomerular disease. Then microscopic hematuria if more than 2 years. So 1 year, up to 1 year is normal, but if more than 2 years, in that case you have to refer. Macroscopic hematuria usually 2 to 3 weeks resolve, but if more than 2 weeks, then you have to refer. More than 2 weeks, and persistent proteinuria more than 6 weeks. Persistent proteinuria can usually resolve 6 months, but here 6 weeks. If more than 6 weeks, in that case you have to refer. Oliguria or AKI, hypertension, C3 level is more than 8 weeks if it is low. In that case, referred. Positive ANA, anti-dsDNA, anti-globular basement membrane antibody, ANCA, and recurrent nephritis. So these are the point 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So 10 point for refer. Okay, and so meeting time is